Welcome to the Seasoned Sonographer, the podcast where experience meets education in the world of OBGYN ultrasound. My name is Lynn Flam and I'll be your host. I'm a registered diagnostic medical sonographer with over 32 years of experience, most of that time in OBGYN ultrasound. Through this podcast, I'm here to share insights, tips, and case studies to help you sharpen your skills and optimize your scans. Whether you're just starting out or you're a seasoned pro, this is the place to grow your knowledge and confidence. Let's dive into today's episode. Welcome to the Seasoned Sonographer. Today we'll be talking about the second trimester anatomy scan and following AIUM guidelines. The second trimester anatomy scan is one of the most detailed fetal assessments in OB ultrasound. There's so much to pack in today's podcast regarding the second trimester anatomy screen that I will go into some detail for some of the anatomy, but for other anatomy like the fetal heart, I'll have a separate podcast and we'll dive really deep into the fetal heart, its anatomy, and how to obtain those images. The anatomy screen is essential for detecting congenital anomalies, assessing growth, and confirming normal development. The anatomy screen is typically done between 18 and 22 weeks for optimal imaging. We evaluate the fetal anatomy for any abnormalities. We measure the fetal biometry, checking for any growth problems, assess the placenta, amniotic fluid, and other maternal structures, and we will provide a comprehensive preliminary report to the referring provider based on our findings. Why do the AIUM guidelines matter? Because they ensure that every necessary structure is documented. It prevents missing abnormalities and small subtle anomalies, and it helps create consistency in reporting across different facilities and different sonographers. So let's talk about the required fetal anatomy AIUM checklist. When you image the fetal cerebellum, you'll be transverse in the head. The cerebellum sits posterior in the fetal brain, and you'll want to look at it for shape, and you'll want to measure it transverse. It always should correspond to gestational age. The cisterna magna should be measured. It is the empty space that contains cerebrospinal fluid behind the cerebellum to the fetal skull. So you would measure from the vermis of the cerebellum over to the fetal skull. It should be less than 1 centimeter. The measurements of the cerebellum and cisterna magna are essential for standard fetal anatomy scan and assessing normal brain development. The lateral ventricles are higher up in the fetal brain. You can see the atrium of the lateral ventricle, and it's filled with the choroid plexus. You want to measure, not including the choroid plexus, at the largest part on the perpendicular axis of the lateral ventricle. This measurement is taken inner to inner and should be less than 1 centimeter. Greater than 1 centimeter would indicate ventriculomegaly and possibly associated with other anomalies, but definitely warrants further evaluation. The choroid plexus is superior in the fetal head. It fills the lateral ventricles. You want to assess that for symmetry. And sometimes you can see tiny cystic areas. Those may or may not be associated with an anomaly or an abnormality. A lot of times it's just a normal variant, and those will resolve or go away. The cavum septum pellucidum in the brain is essential for viewing because it is part of the midline brain structure that's visualized when you're looking at the biparietal diameter, or the BPD. You see the thalamus and the cavum septum pellucidum. The cavum septum pellucidum is identified by 2 little tiny white lines on either side of that midline falx. It creates like a little box, and it's anechoic, and it contains fluid. You can also see in the fetal brain the midline falx. It confirms brain symmetry, and it's the white line running from the front to the posterior aspect of the fetal brain, and should always be seen when you're doing the biparietal diameter. Next is the face and neck. The orbits, they should appear symmetric. They should not be too far apart, indicating hypertelorism, and not too close together, hypotelorism. The profile is packed with information. You want to look at the profile to evaluate the nasal bone, the maxilla, and the mandible. You want to look for any micrognathia. If you see that the mouth is open or the tongue is protruding and it stays that way, that could indicate an abnormality. We want to assess the face for masses, cysts, or any abnormal protrusions like teratomas or encephalocele. Next, the fetal heart. This is a big one. I'll talk in great detail about the fetal heart and obtaining those views in the future podcasts, like I said. But for now, let's talk about the 4-chamber heart. You are sliding down from the fetal head transversely through the fetal chest, and you'll see the 4-chamber heart. You're checking for size. Does the heart comprise a third of the fetal chest? You're looking for symmetry, position. Is the apex of the heart pointing towards the left? And you can confirm that by sliding down real quick and peeking at the stomach and sliding back up. You check the ventricular septum for any obvious large defects. Those small ones are hard to pick up. You'll also want to look at the right and left ventricular outflow tracts. Those should be crossing. The 3-vessel view assesses the great vessels, their size and alignment. The 3-vessel view is superior in the fetal chest from the 4-chamber heart view, and the vessels go from smallest to greatest in size, and they should all be in a line. The 3-vessel trachea view ensures normal connections and outflow direction and forms a slightly different pattern, and you can see the small trachea in that view in addition to the vessels. I always try to get a ductal arch and an aortic arch with my heart views. Those are optional views. So from the chest, we slide down through the fetus transversely, and we can see the stomach. That should be visible in the left abdomen. The heart should point to the left. The stomach is on the left. Further down the fetus, see the kidneys. We'll assess them for shape, size, echogenicity. Always looking for any cysts on the kidneys, any echogenic cortex, any renal pelvis dilation. The bladder can be seen filling and emptying during the scan. If the bladder's not full at the beginning of the scan and you can't see it, then wait. It should fill up by the end of the scan and you can get your picture. I always get a picture of the stomach and bladder and diaphragm all in the same picture so that we know there's no confusion about what we're seeing and that we know the stomach is below the diaphragm. The umbilical cord insertion, look for a normal cord insert to rule out any omphalocele or gastroschisis. You also should look at the cord insert on the placenta and where it goes into that placenta. Sometimes it can be a marginal cord insert, and this is important to note in your preliminary report for the physician. The fetal spine. You'll always want to get longitudinal and transverse views. You'll start at the fetal neck. You want to do cervical, thoracic, and lumbar views longitudinally, looking for that railroad track sign. Note the proper curvature of the spine, looking for any open spine defects, checking to make sure that that skin is intact all the way up and down that fetal spine. Most open spine defects happen down low at the lumbar and sacral region, so always pay special attention to that. You'll look at it in longitudinal and transverse. When you're transverse, the 3 ossification centers form a V. If there's an open spine defect, they will usually form a U shape, and you'll always still be checking that skin intact on the back posterior to that spine. Arms and legs. Assess the symmetry, the length, the movement. Look at the long bones. Measure them if they appear shortened, but just watch those legs and arms move. Make sure there's no club feet, making sure that they don't look abnormal in any way. Check the hands and feet. The hands are usually clenched in a fist, but you can see if there's any extra digit when you get the cute little footprint for the parents. And also just make sure there's no club foot. So let's talk about fetal biometry. The BPD measures the head, and that can be affected by head shape, such as brachycephalic, where the BPD measures wider and the head shape appears more round, or dolichocephalic. The dolichocephalic is when the head is like elongated and the BPD will be shortened. The head circumference is more accurate for growth than the BPD alone. Some optional biometry that can be used to detect skeletal dysplasia are the humerus length, the ulna and radius lengths, maybe tib-fib length. Those are all optional depending on if you suspect any problems with the skeleton. So how do we obtain these views? What are the proper anatomic landmarks? The fetal biometry ensures accurate gestational age assessment and growth tracking. So we want to make sure that when we're getting these measurements, we're getting them the best we can get them to our best ability and checking those landmarks. When you get the BPD and head circumference, you are transverse on the fetal head at the level of the thalamus, the cavum septum pellucidum, and the falx cerebri running down the middle. You're checking for symmetry. You're looking at head shape. You're going to measure the BPD from outer skull to inner skull. That will provide an accurate measurement for the BPD. The head circumference is outer to outer along the calvarium, along that skull. Head circumference is more reliable for dating than the BPD alone. The abdomen circumference. You want to measure the abdomen transverse at the level of the stomach and the umbilical vein. You can see that portal sinus junction. You can also see the spine in transverse with those three ossification centers of the spine forming a V. You can see the aorta in cross section. You measure outer skin edge to include that subcutaneous soft tissue. So you measure out all along the outer aspect of that fetal abdomen. Being accurate is crucial for fetal weight estimation. It can detect fetal growth restriction. That baby is flagged for fetal growth restriction, and it triggers other testing and possible MFM referral. The femur length. The femur length should be fully elongated, perpendicular to your ultrasound beam, so that it lies horizontal in that sector, so that you want to see both those ends of the femur length and a good posterior shadowing. You want to measure the main shaft of the femur, not including those distal epiphysis. The placenta location. Where is it? Is it anterior? Is it posterior? Is it fundal? Is there a previa? If you suspect a previa, you'll measure, and if it's less than 2 centimeters from the internal os, that is a marginal previa or a low-lying placenta. And then a complete previa is obviously covering the internal os of the cervix. Amniotic fluid should be assessed. You can do an AFI and or a maximum vertical pocket depending on what your providers require. We do both. This is to determine if there's polyhydramnios or oligohydramnios. A maximum vertical pocket of less than 2 centimeters is oligo, and a maximum vertical pocket of greater than 8 centimeters is poly. Always check a cervical length in the second trimester scan. ACOG recommends measuring that cervical length during the second trimester scan, even if the patient has no risk factors. This is to help identify a short cervix that might increase the risk of preterm labor. A short cervix is less than 2.5 centimeters. Ideally, you will measure the cervix length vaginally. In our practice, the experienced sonographers will assess the cervix transabdominally and measure it, and if they can't get a good image, or if the patient has a history of preterm labor and delivery, then they'll look transvaginally to be very accurate. Or if the patient is having symptoms of preterm labor or preterm delivery, then always look transvaginally. The maternal structures that you evaluate during the second trimester are just the uterus, looking for any fibroids. If there's bicornate, you surely know it by now. The ovaries, you're looking for any cysts. Measure any abnormal findings of the maternal structures that you see. Common pitfalls. Some common pitfalls are actually the position of the baby. Fetal position and movement are hard to navigate because there's not a lot you can do. You can change the maternal position sometimes to get a better look at the fetus. The baby's movement, you have to just catch it when it slows down or goes into a resting phase. Imaging artifacts, make sure you're always adjusting your depth, gain, and focus. Be sure that you're able to recognize normal variants versus abnormal findings. Know your anatomy and what it looks like, and then you will more than likely see the abnormal. If you can't get a certain image or a certain view, it could be because it's abnormal. Habitus of patients, maternal habitus and BMI are also difficult when scanning. With oligohydramnios, you may use the transvaginal scan for improved clarity of some of the fetal anatomy, and if the head is down, sometimes you can look transvaginally to get better head imaging. Final thoughts and takeaways are these. The second trimester anatomy scan is critical in prenatal care. It's important to document findings correctly for the provider for decision making, including MFM referral and confirmation of your ultrasound findings. Follow the AIUM guidelines to ensure that you've gotten a comprehensive exam. Every sonographer should strive for excellence in obtaining those diagnostic images. Be good at what you do. Never rush the exam. Clarity and quality matter. It doesn't matter how busy your schedule is. Take a breath and spend the time so that you don't miss anything. If you can't get all the anatomy the first time due to fetal position or maternal habitus, always bring them back to complete that anatomy screen another time. And be sure to share your experiences of difficult anatomy screens or cases with me, because I'd love to hear from you and love to hear them. Thank you so much for joining me for this episode of The Seasoned Sonographer. If you're interested in improving your OBGYN ultrasound skills and learning more about the field, make sure to subscribe to The Seasoned Sonographer on Apple Podcasts, Spotify, and YouTube. You don't want to miss any of the upcoming episodes. You can also connect with me on Facebook and Instagram at Sonotechniques Academy. Explore more educational resources on the Sonotechniques Academy app, or reach out via email, lynn@sonotechniquesacademy.com. I'd love to hear from you. If you have questions or topics you'd like for me to cover, feel free to reach out. This podcast is for you, and I want to make sure I'm covering the topics that matter most to you and to the ultrasound community. Until next time, keep striving for excellence in your scans, and I'll see you in the next episode of The Seasoned Sonographer. The information provided in this podcast and any accompanying materials is for educational and informational purposes only. It is not intended as a substitute for professional medical advice.